Hello, everyone, and thank you for joining us today. My name is Natalie Boyum, and I'm the president and founder of the Defeating Epilepsy Foundation. We are a 501c3 not-for-profit in Southern California, and our mission is to provide the advocacy and educational resources needed to the epilepsy community and our society. Today, our guest is Dr. Varun Desai. Dr. Desai is the Director of Pediatric Surgical Epilepsy at the University of Oklahoma. Dr. Desai uses advanced technology to help with diagnosis of epilepsy in the University of Oklahoma's Level 4 Epilepsy Unit. Thank you, Dr. Desai, for joining me today.
Sure. Thanks for having me. It's really a privilege to help out and to come in and be here with you right now.
Thank you so much. Today's discussion, we are focusing on the advancements we are making in healthcare when it comes to diagnosing and treating epilepsy. Epilepsy monitoring units are important for patients with epilepsy who are trying to get a proper diagnosis or are seeing if they are eligible for surgery. More funding is needed for research and treatment for epilepsy. But we also need to focus on helping patients set goals for their overall wellness and improve doctor-patient relationships. Dr. Desai, can you please explain what epilepsy is?
Sure, that's a great question. So, epilepsy in kind of our everyday language is really just known as multiple seizures. There's several international and national organizations, specifically the International League Against Epilepsy, that really defines it as a disease that's characterized by an enduring predisposition to generate multiple epileptic seizures, as well as all of the neurobiological, cognitive, psychosocial, psychological consequences of this condition. I think what's important to note about that is that not only do they characterize it as a disease, but they also characterize it as something that takes a toll on one's real entire life. It's really not just about multiple seizures, but also what happens in between those seizures. It takes a toll on a child's normal development, ability to think straight, to have a normal mood. There's higher rates of depression and anxiety with these children. If you just imagine a kid who's in class and he's really just thinking about the next seizure he's going to have, and scared he's going to have it in front of the whole class, he's obviously going to be very anxious about that. He's not going to be able to pay attention in class. His mood is going to be affected. If you think about an adult with epilepsy, they're not allowed to drive. They have to be careful doing simple things like walking up and down stairs and swimming. And so it really affects someone's everyday aspect of their life.
Oh, absolutely. And I can totally understand where you're coming from when it comes to lifestyle of children, adults. I was very heavily medicated as a child. I was on phenobarbital the first 10 years of being diagnosed with epilepsy. And even though I did, for the most part, well in school, it was such a struggle getting through school with the level of fatigue I felt from phenobarbital. And even as going through teenager, having being on multiple different combinations of medication, it really has a impact on your social development. I've been very lucky. My seizures have now been controlled for 16 years, so I'm able to drive. But I can say as a teenager, seeing my friends get a car for their 16th birthday and knowing, was I ever going to have the privilege of driving? It really had an impact on my emotional, mental well-being at that point, feeling so limited compared to my friends. And even now as an adult, even though things are controlled and I'm educated and I've done a lot more with my life compared to sadly some people who never get their seizures under control, I still feel that stigma as an entrepreneur, people, guessing, do I really have the capability of having a successful career just because of having a history of seizures? So it really is a very challenging condition that I think a lot of people don't realize how much it has an impact, as you just stated.
Right. Very well put.
Yes. So how do you manage epilepsy?
Well, as you mentioned, the first line is medications. They do work great for a lot of people. About 50% of people will just take one medication and have no more seizures. Unfortunately, there's a lot of people, the other 50% that don't respond to that one medication will need a second one, and only about 10% of those people will respond. And of the remainder, only 3% will respond to any more medications. And like you mentioned, these medications are very strong. They make you sleepy, you can't think straight. But the more important thing is if you've taken two medications, the chances of a third or a change in your medication regimen actually helping is almost zero.
Oh, wow. See, I
Yeah.
didn't realize how low it was. It took 24 years in different forms of medication before they found something to control mine. The only thing that has ever worked for me is carbamazepine. Every time they've taken me off of carbamazepine to try something new, I start having seizures again. But they found that because I have seizures due to traumatic brain injury, along with the carbamazepine, they have me on lamotrigine, but that is more for a mood stabilizer to decrease my stress levels so that I don't trigger any unnecessary seizures.
Yeah.
So I think it's really interesting. I mean, a lot of people, I think they think of anti-seizure medication as just stopping seizures, but it plays many roles in
Yeah.
helping people with their well-being.
Right, right. Yeah, that's a good point.
So can you explain for our supporters what a comprehensive epilepsy center consists of and why they are important for people with epilepsy?
Sure. Yeah, that's a great question. So, the way to describe a comprehensive epilepsy center is really a concept. It's where basically a group of epileptologists, epilepsy surgeons, epilepsy specific neuroradiologists, neuropsychologists, and therapists all get together to discuss and figure out the best way to manage and treat a patient. So there's lots of hospitals that have a surgical department or a neurology department or a radiology department, but they don't communicate. They don't come together and in person discuss each one of their patients and their point of view on why they think this is the best medication or management plan or whatnot. But a comprehensive epilepsy center not only has those departments, but all of those departments actually get together to discuss each patient. And so because of that, there's 4 different levels, as you mentioned, and that all has to do with the different modalities and different treatment algorithms each one is capable of offering, the different resources they have, with level 4 being the highest, meaning they can offer really any type of therapy to any epileptic patient. So the National Association of Epilepsy Centers has really recognized this as making a real impact in epilepsy patients, specifically those that are intractable, meaning they're not responding to medications. And they've made an urge that if somebody has been taking 2 or more appropriately trialed medications for 3 months and they're still having seizures, they should be seen at a comprehensive epilepsy center. And once they're seen there, they go through a different phases of workup and management. It could be just as simple as changing their medications around if they're on the incorrect ones or an incorrect dosage, regimen, whatnot. It could be that they just need a ketogenic diet is one of the ways of treating epilepsy. Or it could be that they just need somebody to help with their comorbidities, their mood, a neuropsychologist to help with their cognitive development, therapist to help with their speech or any other kind of therapy. And then lastly, if they're deemed to be somebody who could be a possible surgical candidate, they would go through a series of steps to determine that and how best to approach that.
And I think all those things are very important. But what I really like hearing about is the fact that you have a team coming together to help patients, because I can say myself, before I even knew there was such thing as an epilepsy center, an EMU, I had many doctors where if I was very depressed, well, go talk to a therapist, go talk to a psychiatrist. But it was frustrating because I could tell both teams never talked to one another. My neurologist didn't know how he's doing in therapy, or for a short time when they saw me see a psychiatrist, the only way my neurologist knew what the psychiatrist was doing was because I went and discussed what was going on during session. And I think it's so important for doctors to come together and collaborate to increase the chances of their patients having a successful outcome and improving the quality of their life.
Right, absolutely. You know, a big thing also is that each department has something else, something different to offer, and we may not be aware of all of the different things that another department can offer. So we're all sort of fixated in our own field and kind of looking in one direction. You know, a hammer only sees a nail, and so I might be seeing a surgical patient, and the neurologist may say, oh, well, we could try this medication or just a ketogenic diet, and then we don't have to do surgery at all. Or they'll say, okay, well, let's try a bunch of these medications because you're not a surgical candidate. But then I see them and I say, well, you're clearly a surgical candidate and a very easy and safe fix. So bringing that all together is really what's important about these comprehensive epilepsy centers.
Oh, absolutely. So which patients are appropriate to be seen at a comprehensive epilepsy center?
Yeah, that's a good question. So there are a lot of people who will have a seizure one time and then that's it. Especially with kids, they may have a febrile seizure, as we call it. They get an infection, their temperature goes up, and they have a seizure one time. They don't need any medication. They don't have any more seizures. That's not the appropriate type of patient. Or if there's a patient who has a seizure or multiple seizures, but then starts taking a medication and then they're controlled and they're tolerating their medication, they don't need to come to a comprehensive epilepsy center. It's basically those people, that 50% are really 30 to 40% of people who are what we call intractable to medications, meaning they've tried 2 or more anti-epileptic medications and they're still having seizures. And it's not, we don't really include or really count side effects as part of that piece of the puzzle when we're counting these numbers. Meaning when we say 30 to 40% are unresponsive to medications, we mean that they're still having seizures. There's a significantly higher proportion of people who are having side effects, like you mentioned, lethargy and brain fog and all of that. And we don't even include those people when we count that big number. So.
No, and that's very important because a lot of my work, along with trying to improve doctor-patient relations and helping patients to learn to advocate and set goals for themselves, a lot of times I've talked to entrepreneurs about people who have epilepsy or other neurological disorders, or they're neurodivergent, how they can, despite their challenges with their seizures controlled, they can contribute to society. And I think one of the biggest challenges has been convincing entrepreneurs with the advancements we have in technology and what we're able to do to set up in an environment. There's no reason for people with neurological disorders or who are neurodivergent to be discriminated against in the workforce anymore. In fact, they're showing studies that these people are above average IQ, many of them. They love repetitive work, and if you put them in the right environment, they will just blossom. They will show their potential and they can benefit many companies.
Right. Yeah, I think there's a lot of stigma with epilepsy patients that really needs to be cleared up. But you're absolutely right.
So for someone who is being considered for surgery, what should patients do to prepare for their visit and what should they expect?
So, I kind of mentioned briefly the phases of evaluation that a patient would go through. If somebody were to be seen at a comprehensive epilepsy center, before even talking about surgery, we figure out if they could even be a possible surgical candidate. And so there's 3 different types of imaging that we can get on a patient. It would be a structural type imaging, like an MRI or a CT scan, where we're actually looking at the the gross macroscopic structure of the brain. There's electrophysiological, where we look at the EEG, the brain waves, the electrical waves that we're detecting. And that would be via an EEG, or what we call an extended EEG, where they're in the epilepsy monitoring unit for a number of days. And we detect what the brain looks like when they're having a seizure, where it's coming from, and what the brain looks like in between the seizures. That gives us an idea of where to kind of pinpoint the focus of the seizure. And lastly, we can look at metabolic changes in the brain during and in between seizures. And it's a PET scan or SPECT scan that look at the blood flow in the brain. And basically, if we think about it, when we're having a seizure, that part of the brain is very active, and so it requires more blood flow, and we can detect that with imaging. And then in between seizures, because it was just so hyperactive, it's tired out and the blood flow is decreased, and we can also image that. So what we do is we put together this structural, electrical, and this metabolic imaging, and we put it together with the way the patient looks when they're having a seizure. Is it starting off on their left side or right side? Are they looking one way or the other? Are they having lip smacking, or something like that? Those all kind of give us a clue as to where the seizure is coming from. So that if we take all of that data and we come together in our comprehensive group, we have the radiologist going over the anatomic imaging, our neurologist going over the electrophysiologic imaging. We also have the neuropsychologist. They can do a battery of cognitive tests to kind of determine where some of the deficiencies may lie. Is it a verbal reading problem? Is it a motor problem? A comprehension, all that kind of stuff. And we can try to narrow down where we think the seizure is coming from. And if we can identify a single focus that the seizure is emanating from, then that gives us an idea that, well, we can treat this surgically. And then we start thinking about different surgical ways of fixing that problem.
No, that's very good. I think from a patient perspective, we don't always realize the complexity of epilepsy, with there being so many different types of seizures and what is causing the epilepsy, and that this is a puzzle that doctors are putting together, and it's such an individual case. There's nothing how can I put it? I guess you could say there's nothing of a recurring pattern. Each patient is a case of their own.
Exactly. And not only that, but a lot of people who have pretty severe epilepsy will have multiple different types. And, let's say they have 5 different types of seizures. One could be coming from, the right frontal lobe, for instance. Another one could be coming from the left temporal lobe in a completely different area of the brain. And so what we do when we get together in our comprehensive center is we say, well, it looks like these seizures are coming from here, these seizures are coming from here, but their most dangerous one is coming from here. And that's the one that we need to treat. Some people may have, these smaller seizures that really don't affect their daily life. The ones that do affect their daily life is maybe the one that makes them pass out and fall, and they hit their head and they have to go to the emergency room every so often. That's the most dangerous one that we want to target.
Oh, absolutely. There are different types of EEGs for patients with epilepsy. One type you mentioned to me was a stereo EEG. What is a stereo EEG, and how are they different from a typical scalp EEG?
Yeah, that's a good question. So I mentioned these phases of care that people go through once they get all of that first set of non-invasive imaging. When we put together all of that and try to decipher where the seizure is coming from, a lot of times we can figure it out, but a lot of times we can't figure it out. They're kind of giving us confusing information. One modality says right side, another modality says left side, and so it's still kind of a gray picture. What we can do in those instances is a stereo EEG, which is basically an invasive EEG, where we place electrodes directly into different suspicious parts of the brain and monitor where the seizures are coming from with those electrodes. So a typical scalp EEG, which most people will get when they place the electrodes on the skin, those actually have to detect the brain waves through the bone and through the skin, which is very thick. And so because of that, the brain waves are very dampened and we get a very poor spatial resolution from that. We're not able to detect a lot of the seizures, and the ones that we do detect, we can only really do so with about 2 to 5 centimeter of accuracy. That's a really big area when it comes to the brain, especially if we're thinking about surgery. So a better way to do that is the stereo EEG. So when we place these electrodes, we can really define a seizure focus in the range of 1 or 2 millimeters. And what we do is we don't shave any of the hair. We make a really tiny 2 millimeter incision, and we use this fancy MRI technology that tells us exactly where we are in the brain, and we make a plan accordingly so that it's a safe way of doing it to make sure we're not near any blood vessels. And then we have a robot basically help us do this.
Oh, wow.
Yeah, and it's so it's worked out great. So we've been able to put these electrodes in about 1 millimeter within a millimeter of where we want it to be. And the chances, the risk of complication is very low. It's less than 1%.
Oh, wow, that's incredible. I know you work with children a lot. If you have to do something like this on a child, how do you find is it more challenging to work with children than adults? Because the first thing I would be thinking of, are they going to pull on the wires? How are they with testing?
They've been very good, and I think that's a great question because not only are they younger, but they're also, because of the epilepsy, they're going to be slightly delayed cognitively, and so they may not know what they're doing. I mean, they don't know what they're doing when they're kind of reaching for their head, trying to scratch or whatnot. So when we put these in, we put it in with there's a metal bolt that sticks into the bone, and so we put it in firmly, and then the electrode comes out of there. Um, and these don't hurt. It sounds scary, but they actually, the pain is really not a big deal in these cases. Um, the thing that really bothers them more is just kind of sitting in bed waiting for the seizure to happen. But we kind of wrap a big bandage around all of this, so they have basically all you can see is a big white ball,
Yeah.
and the electrodes coming out at the top. So they're not really able to kind of mess with the hardware at all.
Oh, that's good. No, because even myself being in the EMU or having was it the longest EEG I had was 72 hours. And even as an adult, by the time I hit the third day, between the edginess of my scalp or anything, I even had to tell myself, don't touch it, leave it alone with how it feels. So I can't imagine as a child, you don't have as much patience or understanding why it's important not to touch it. The
Right.
temptation be there to grab it or getting frustrated and trying to pull on it.
Right. And it is the sensation is going to be slightly different from a standard EEG because they have to put that some of that putty to basically stick the electrode on. That's pretty itchy, and the when they put the electrode on, they put a little mesh over that can be pretty itchy, covering a pretty big area. When we do this, we actually shampoo the hair before we put the bandage on. That way we cleanse it of all of the material that we use to prep or prepare the scalp with the antiseptic or antibacterial solution. Those can be pretty itchy, so we shampoo it to get that all off, and then we put the bandage on, and it's covering a very small area of the skin. So the itchiness has not been too much of a problem in these cases.
Oh, that's good. So once doctors find the location where seizure activity is coming from, what options are available for patients that are minimally invasive?
That's good. So So after we put the stereo EEG electrodes in, we monitor them for several days in the epilepsy monitoring unit. And as I mentioned, we can really define the 3D picture of the epileptogenic zone where the seizure is coming from, what we call the bad brain. And we can do that with a resolution of about 1 or 2 millimeters. So we take that information and then we formulate our surgical plan. And if it's something that's near the surface of the brain, it's a big area, it's not near anything that's important, it's not close to our speech center or our motor center, then what we can do is offer an open resection where we basically just take that tissue out.
Oh,
If it is close to an important part of the brain, it's close to the speech center, or if it's in a deep part of the brain that's not easily or safely accessible, then we can put in a laser fiber and burn it. And what we do when we do that is we make a small 2 millimeter, 3 millimeter incision. We put this metal bolt into the bone and then put a 1.6 millimeter diameter laser fiber into the bad brain. We use a robot and we use the fancy MRI that tells us where to go to put this in. We can put it in within about a 1 millimeter of where we plan to put it. Once we put it in, we transport them to the MRI scanner. In the MRI scanner, we start heating up that tissue, and the MRI scanner is actually checking the temperature of the tissue, and it's doing that every 6 seconds. And
oh,
so
wow.
it's telling you how hot that bad brain is getting, but it's also telling you if any of the normal brain around it is starting to heat up. So if we see any normal tissue starting to get warm, then we turn the laser off. Otherwise, we'll keep the laser on until we burn the entire area of the bad brain. Once we're done, we just take it out, we put one absorbable stitch in, and usually they go home the next day.
Oh, nice. Because in a way it sounds quite invasive, but at the same time, the fact that you can monitor the temperature to make sure you're not causing any damage or complications, it's quite amazing compared to what they only could do so many years ago.
Right. Yeah, this is a relatively newer technology. And so yeah, we're able to access really any location in the brain and treat it this way. Now, the last one I'll mention is if the seizure focus is actually inside a part of important part of our brain. So let's say our speech center and it's coming from that area, then we can't burn it, we can't take it out because then they'll lose the ability to speak. So what we can do in that case is we follow the same steps. We don't shave any hair, tiny incision, use the robot, we put this electrode into this seizure focus, and we connect it to a battery. And what that battery does is it detects the abnormal brain waves. And anytime it detects an abnormal brainwave, it sends an impulse to block it. So what it does is once it starts detecting a seizure forming, it sends an impulse to stop it before the patient even knows what's happening.
Oh, that would be like an RNS system,
Exactly.
hooking up the leads and having, oh, wow.
Exactly. Yeah.
No, that's pretty neat because I mean I've researched about VNS and RNS, and I've always wondered what specifically are the benefits from both. What would make doctors decide what one to use?
Yeah, the main differences are, the VNS is basically what we consider a palliative option, meaning, and then that kind of gives a bad connotation to it. But it's basically the option when there is no better surgical option. So if we were to try to figure out where the seizure is coming from and it tells us it's coming from everywhere in the brain, then VNS is really the only option there, or one of the only options. And what that does is we hook up an electrode to one of the nerves in the neck, and it's constantly sending an impulse through the entire brain. The chances of that making somebody seizure free are almost 3 times the chances of medications working in the appropriate patient. So they're still much better than medications, but it's the worst surgical option. And RNS is something different. RNS is actually pretty cool because we put the electrode directly where the seizure is coming from, and it detects it and it sends the impulse, but it also learns over time. So it starts to learn how the brain is firing when a seizure is happening. The first time it detects it, it's good, but it's not great. But then it learns, okay, well, last time this is what the seizure looked like, so that's what I'm going to be looking out for next time. And the next time it sees that, it sees it more readily, and it sends an impulse faster and stronger. And so its ability to control seizures gets better as time goes on.
No, that is quite cool. I've known a couple of people who have got an RNS, and they said really the only complaint was in the beginning with the device learning the pattern of the seizures, and at times them having to have the doctor adjust it so that the impulse it gave was not too intense. Or a couple of people have told me in the beginning it was painful, but once they saw the rhythm of it and the system of it, the doctor could adjust it, and it really made a difference.
Right. Yeah. And that's a good point. That's another piece of the puzzle where we can just put a magnet or really a radio frequency controller on the surface of the skin and change the settings of VNS, RNS, and all of that to reduce the stimulation, intensity, the frequency, all of that.
It's very, very interesting. So what are the chances any of these options will help stop seizures?
That's a great question, and it's also a tough one to answer. It all really depends on what we're up against. Um, when we think about, when we do this battery of tests and we're able to locate a single lesion where the seizure is coming from, we have an option to treat it with either taking that piece of bad brain out or burning it. The chances of that stopping seizures are about 60 to 80%, which is, it doesn't sound like a great number, but that 60 to 80% that will never have a seizure again. And the other 20 to 30% or so will have a significant reduction in their seizures. They may have an isolated one here or there, but it'll be less severe, less frequent. Only about 5% will continue to have seizures after a big surgery like that. If we were to place the RNS, since it's relatively new, we're still sort of gathering data on this. But what we've seen so far is about 60 to 70% of people will have about a 70 to 80% reduction in their seizures. Meaning, if we were to kind of rate the seizures in terms of number somebody was having or severity, we bring that down by about 4 or 5 times for most people. That's kind of the end result that you could expect, which is very good. And
Oh,
then
absolutely.
and VNS, our worst option, is about 50% of people getting their seizures cut in half. And then another way to look at it is about 8% of people having no more seizures, once a VNS is placed. So, again, 8% is not a great number, but it is still a lot higher than the third medication if medications are not working.
No, that is a very good point. And, there's been times I've had a couple friends who had VNS. Is probably one of the most interesting cases I heard. I have a friend who has temporal lobe epilepsy, but he has it in both his left and right temporal lobe. So if it happened in his left temporal lobe, he had focal seizures. If it happened in his right, it started off as a focal and then turn into a generalized seizure. And when they did the VNS, it didn't stop the seizures completely, but the severity and frequency greatly decreased.
That's great. Yeah. The thing that makes, there's a lot of things that make epilepsy very difficult. But one of the things that can make it very difficult also is when we identify two different areas that the seizure is coming from. A lot of times it's hard to tell if it actually is two independent seizure foci, or is it that one is starting off and it's quickly spreading to the other one, and the other one is really just seizing as a result of the first one. And that's what we have to kind of figure out when we get together in our comprehensive group. Do we try to treat both lesions, or do we try to treat one, because it seems like everything is originating from there and fast and quickly spreading to the other one?
And that's really interesting. I don't think not everybody, but a lot of people don't realize the complexity of that. If it's affecting multiple areas of the brain, what area do you even focus on? What do you even start with before you can even put a treatment plan or any level of goals together?
Right, right.
So for children who are battling epilepsy, what resources can the Epilepsy Monitoring Unit offer to them?
So, you mentioned, getting impatient at about the 72-hour mark when you're in the epilepsy monitoring unit. So, I mean, I think that's pretty good. I would probably get pretty impatient at the 24-hour mark or even the 8-hour mark. But these kids, they have to stay in the hospital, in the bed for 5 to 7 days, just, monitoring for seizure activity. That's a really long time. That's an especially long time for a child. Um, I mean, it's not just that you're laying in bed, but it's also that people are around you all the time. You can't even really go to the bathroom in private.
Yeah.
So it's tough. And so we really try to do our best to keep the kids entertained. So we have a specific group within the hospital that their entire focus is keeping the kids entertained. And so they have a whole, closet of board games, card games, video games. They have probably the most entertaining for the children is the dogs. So they have four therapy dogs that come by. And these dogs love to jump on the bed and cuddle with the kids, and the kids
Oh,
just
how
absolutely
sweet.
love it. Yeah.
Uh, No, my sons have hemophilia, and for our supporters, what Dr. Desai is talking about is there's a group of specialists who are known as child life specialists. A lot of them are social workers or psychologists who go on to specialize in this, and they really are a very essential, important part of any children's hospital to help with what Dr. Desai is actually saying, the emotional, mental well-being of trying to keep children calm and as comfortable as you can in a situation like that. And I feel child life specialists don't get enough recognition for the amount of work that they do to achieve that goal.
Yeah, I completely agree. That's not an easy job, but they're good at it.
Yes, very, very much so. So what options are available for patients who are not surgical candidates?
So that's a good question. We already kind of talked about the vagus nerve stimulation. That can really be an option for most people, because that's basically just sending out an impulse through the entire brain when we can't find a single focus. The other options would be ketogenic diet. We don't necessarily understand the mechanism by which it works. But we have a team and a whole department here at OU to specifically address that. And basically, it's a high fat, low carb diet, and I won't get too nitty gritty on the details, but basically, you start when you eat that kind of diet, you force your body to use fat as the energy source instead of glucose, which makes you produce ketones, and that somehow leads to a reduction in seizures. Um, so we've seen it work. It is something that is tough because you have to be very dedicated in your nutrition. But that can be an option if surgery is not.
Yeah, and I think what's really important for people to understand about the keto diet, because I found not even just in treating medical conditions, but I used to before I had long haul COVID, I'm getting my strength back, but before I experienced that, I was very physically active, and one thing that was very popular for people who were training and wanting to reduce their body fat percentage, keto was a very big phase. And I try to tell people, we did a presentation on keto, and I've had a lot of people ask me about keto, and there are levels of keto diet that are very specific, that it's actually under the guidance of a doctor nutritionist. And then some of the other ones, such as intermittent fasting, where you don't eat within a certain time range, that's, you know, similar to keto, produces ketones, but it's not under the observation of a doctor. So I feel that when we talk to patients about keto, or even the general public, how important it is to understand that it's not a just one diet, how depending on what you're trying to treat, how important it is and how strict it is to follow it.
Right. Yeah, that's very well put.
So let's see, where's it? So for a patient who is being admitted to the epilepsy monitoring unit for the first time, what would you suggest to them to prepare for their visit?
Yeah, I think, I obviously can't put myself in those shoes. I can't imagine how scary and how not fun it's really going to be. Um, but what I would say is, try not to focus on, how horrible it's going to be, but think of half glass full. That's an opportunity to get more information, and hopefully one day enough information to figure out a plan to make you seizure free. So that's kind of the way that I would approach it.
No, I agree. When I had my recent visit, I did, you know, what I could. I knew to keep busy, such as bringing my computer and doing some work, reading some books, watching TV, communicating with friends on Zoom. I found that it really helped a lot. I think the only frustration was, and this is just because I'm normally a very on the go person, having to ask, you know, call and ask, can someone go with me to the bathroom, or can I get up and do this? I know that I will admit, with my personality, I didn't like having the alarm on the bed and being told, if you get up, we're going to know you're getting up. We're going to know you're up to no good, not listening. So I think that was just the biggest challenge I had.
Right. Yeah, no, it is very tough. I can only imagine. So
Oh. But is there anything else you would like to share with our supporters today?
I just want to say thanks for this opportunity, and um, I hope that everybody can kind of learn a little something from this, and hopefully ease their mind. I'm sure having epilepsy, you have a lot of questions about what it means for the future and what options are available. Um, what I would say is that there is always research going on and newer technologies, newer modalities. A lot of these minimally invasive approaches did not even exist 5, 10 years ago. And we're just kind of snowballing in that direction. So keep looking out for different treatment options.
Oh, absolutely. So that is all the time we have for today. Again, I want to thank Dr. Desai for coming and taking part. To see the great work we are doing, please like our social media pages and subscribe to our YouTube channel. We invite you to visit our website at www.defeatingepilepsy.org to see how we are making a difference for the epilepsy community. Thank you for your support, and together we will defeat epilepsy. Take care.